Great, well, so I'm Sarah Rodgers and I've come here today from the University of Liverpool, and I'm going to give you a more academic talk, so it's a bit of a hard line to follow, those last two exciting presentations, but I'll do my best. So the work that I'm presenting on, I did in Swansea University, where I was until about a year ago, and I used something called the SAIL Data Bank, which has a good mechanism for linking environment to health data. So I'm going to talk about our housing regeneration and health study. So this is the before and after shot of a couple of houses in Carmarthenshire where this study was set. And so you can see the after photo has been taken on a nice sunny day to make it look even better. I don't know whether the insulation measures are as good as the ones that Ian was talking about, but this house here at the bottom has got external wall insulation, which makes it look quite different. And so I'm going to talk about all the usual academic sort of research questions, methods, etc. in the talk today. This intervention, there was £138 million invested by Carmarthenshire Council that they got from the Welsh Government to improve houses up to the Welsh Housing Quality Standard. And I've been hearing that perhaps the Welsh housing quality as a whole, this is from Twitter comments I've been looking at this morning, isn't as advanced as some of the housing quality standards in England, and we need more better laws there. But hopefully this work could help improve those laws. So Carmarthenshire, the setting is just west of Swansea, so it's similarly wet and mild as Truro, so you can see the similar housing conditions. So we're also worried about mould and damp and things like that. So this was a whole housing, a whole home intervention. So they had new windows and doors and bathrooms and kitchens, insulation, and they even had their garden paths made safe as well. So Carmarthenshire Council told us that the intervention, that these big housing improvements were starting in 2009, but when we got the actual data, we could see that they had some pilot work done from 2007. So if we'd done a normal academic standard approach of them, just believing them and doing the analysis from 2009 to 2015, then we would have got an awful lot of the garden paths and windows and doors and a certain amount of elements were all already sort of half complete, as you can see there. So what we did was we got the data from Carmarthenshire Council, and then we could see exactly what they were doing when. So garden paths, for instance, they were already nearly 70% complete. So what we did was we wanted to ask several research questions. Does improving these houses benefit the physical and mental health of the residents? And what we did was compare the changes over time for the people living in the homes that received these interventions for each different housing intervention element. So we did for bathrooms, we looked at the intervention group, those who became compliant to meet the standard, compared to a reference group that weren't compliant. And because we used an anonymised data bank, that I'll mention not in too much detail, so don't worry, just a little bit, we could actually bring in all the other people in the rest of Carmarthenshire, which was about 300,000 people. So we had a big reference group. And the outcome measures we were very interested in, what did we actually change in the end, were emergency admissions to hospital for these conditions combined. So we looked at a primary outcome measure of cardiovascular, respiratory and injuries, fall and burn injuries. And then we actually, because we had quite a big data set, we actually looked at each of those separately as well. But our main outcome was those all squashed together in one outcome variable. And so we got the data from this SAIL data bank. And the Carmarthenshire County Council recorded very well when they had their kitchens and bathrooms and insulation updated, and they recorded it against a unique property reference number, and we fed that in via our health informatics team, the NHS Wales informatics team, and that allowed us to link all that regeneration data, but not have revealed to the researchers where the location of the houses were, so it was all still anonymised. And then we could create links from the house data to the people and then to their health conditions. So I won't go into any more complicated detail about that today. This was a very complex intervention. This is a slide that the statistician who was working on the project drew to try and understand what was happening when she first came into the project. And so all the vertical lines are sort of the different interventions, the new bathrooms going in, the new kitchens, etc. And the horizontal lines represent the different people. And what this is meant to represent is that it is a very complex intervention, and we could take account of new babies coming in and people dying and people moving away and people moving from one house in the Carmarthenshire social house. Sorry, I forgot to mention, these are all social houses in Carmarthenshire. One social home to another, and there was about 10% of people moved year on year. So it was because we had this data bank though, we were able to sort of anonymously follow these people around, so we could continue looking at what happened to their health outcomes even when they moved, which is quite a valuable thing. Unlike the Smartline project, we don't have a lot of measures of the internal the humidity or the behaviour change of everybody, so we just had whether they went to hospital or not, and we were unsure about the sort of dose of the treatment. So we had whether they needed to be updated to meet the Welsh Housing Quality Standard for insulation, but they may have already had some insulation, for instance. So we don't quite know the extent of the change itself, but we know in the end that they met those conditions. So I'm not going to spend too much on that. If there's any statisticians in the audience, there's a bit of Greek for you. Just to say that we nested the timing of the hospital events within individuals and then within a community, and we had a very proficient statistician called Damon Berridge on the team who helped us analyse this very complicated data set. I think Rowena said, was there about something like 3 million rows of data, and she had to get a extra dedicated workspace to process all the data, so it's very data intensive. Okay, so I want to share with you some results from the project. It's got right into the important point here. So this is our combined health outcome for respiratory, cardiovascular conditions and injuries, and this is for our older people who are 60 years and over in these social housing in Carmarthenshire. And what you can see here is that so we've got a 30% reduction in hospital admissions. So anything this side of the line is good. So, and anything where the red bar doesn't cross the central line is good as well. So everything was to the left of the central line is really significant. And we had nothing going to the right of the line, which means we made more hospital admissions. So everything to the left was a reduction in hospital admissions. So, for example, the windows and doors there at the top, there was a 30% reduction in admissions. The wall insulation, we reckon, nearly as big a reduction. The interesting one there is the electrical systems. So we had nearly a 40% reduction in emergency admissions to hospital for these three combined conditions. And we think that's because the electrical systems included extractor fans in the kitchens and bathrooms, and it removed the damp. So, so what happens in the Welsh Housing Quality Standard, last time I looked, I don't know if our work has had any impact since, last time I looked, the removal of damp was seen as a secondary comfort criteria rather than one of primary importance or safety. And so what I would like to see happen is for that secondary comfort criteria to move into the one of safety, because then I think you can see that the importance of respiratory systems. So the electrical systems for respiratory. So when we pulled apart the respiratory, cardiovascular and injuries into their separate components, and we could do this because we had, I think for our older people, there were 7,000 older people in about 8,000, 9,000 homes. Is that right? Yeah, so there were about 7,000 older people over the fairly long period. I think it was 10 years of follow-up that we had. And we showed that for respiratory conditions, this it moved even further this way. So there was about I think it was about nearly 60% reduction in emergency admissions when we looked at the respiratory conditions on their own. So that made us think that it's even more important to have something, the electrical systems, removing the damp there. So that was for our older people. So for all ages, we show a similar pattern. So there's a 20% reduction in admissions for all ages as a result of having windows and doors. I spoke to a very eminent statistician about these results, a chap called Peter Diggle, who's at Lancaster University, and he said that what we have is something called orthogonality in our results. So basically, this means there's a bit of seepage between the different elements. So perhaps as a result of having the windows and doors and wall insulation, electrical systems and garden paths that I haven't talked about yet, is all sort of adding to this seeping out and having an impact on these outcomes. So garden paths is an interesting one. There's no real thought-through mechanism for this. I don't know why garden paths would impact on cardiovascular conditions and injuries for people. So that's a bit of a strange one. And perhaps, maybe we're seeing a seepage out from the other external elements of the housing improvements, such as the windows and doors, perhaps. So this is a cohort. We looked at asthma and COPD as well, but we made sure that the people who were in this cohort, they definitely had a diagnosis from their GP for asthma and COPD. So there's only 8,000 of them instead of 20,000. So there's some indication there that something's happening, but it's not very. You can see the bars are quite narrow there, but there's not many significant findings. So we had a 10% reduction in prescriptions and a 10% reduction in GP attendances. So that is something to talk about. So there's a 10% reduction in GP attendances for people with a common mental health disorder as well, and that's just about not significant, but it shows there's a pattern there as well. And this is emergency attendances for all ages. So these are people that are perhaps, so they've gone to the emergency room, but they haven't been necessarily admitted to hospital. So it's more minor injuries. And you can see there that this is the only one that goes shooting off that way. And we've got a 20% increase in injuries for garden paths. And perhaps this, I thought, might be because people have their exterior gardens all made lovely. And you've probably got people my age who are running around in the back garden, and even though the paths are meant to be made safe, perhaps they're using their outdoor space and falling over and maybe kicking a football about, and middle-aged people get suddenly active when they haven't been, and maybe that's what's happening there. So you can see we've just got the data here. We haven't got all the behavioural change information as you're collecting in the Smartline. So, but it's really interesting, nevertheless, I think, to see these objective results here. So, for instance, we don't have any recall bias. There's no, and we collect the data for everybody. We didn't just get the little old ladies who are home in the middle of the day, as you possibly would with a survey. And we didn't depend on people remembering whether they'd been to hospital or not. We actually knew from the anonymised data that they had or hadn't been. We had complete data for the hospital admissions. We had 138,000 person years of follow-up in this massive data set. And we think that because we had multiple confounders, we think this is generalisable. So, for instance, there's probably similar things going on here in Truro if they had the same housing improvements made. We didn't have any randomisation. So the Department of Health still likes people to do studies that are randomised. So it's a very academic thing, and it's very hard to do because you'd have to randomly allocate people to have the housing improvements, and you'd have to put people in a long waiting list. And when the rest of your community is getting everything done, if they missed out your house on the street, I think that would be quite upsetting. So it's quite very difficult to do in this community setting. As I said before, we didn't have quite enough information, I think, on the status of the house before it was brought up to the Carmarthenshire Home Standard or the Welsh Housing Quality Standard, so we didn't have a real grasp of the dose. And the orthogonality thing, how do you say it? The statistical thing that I mentioned earlier, we think there might have been a bit of a lack of independence between the work elements, so there's some limitations there around the statistics. Just to say, this was a 5-year project, and I was quite shocked at the end of the 5 years about how many of my co-investigators retired. We did have on the panel Pam Every, who was the chair of the tenant group, so we did have some input from the community. But as with an anonymised data bank study, it was quite hard to get that behavioural element in there. I have tweeted about a sister study of ours called RBED, which was run by a colleague in Cardiff University, and they did have focus groups and survey groups as well. So but the intervention there wasn't a whole home intervention. It was just about putting insulation on the homes. And I should mention that Carmarthenshire were a really good landlord. They adapted their interventions to the people. So they asked them what tiles they would like and what fire surround they would like and things like that. So we haven't captured any of that either, but I think that has come through in some of the results probably. So it's not just okay to do these interventions to people. You have to do it with them. And I've also put on Twitter this report, so if anyone wants to read it, and the RBED one as well.